afternoon, everybody. I'm Dr. Kartik Vishwanathan. I'm going to present on applied statistics. I would like to thank Dr. Raju Vishya sir and Dr. Lalit Mini sir for inviting me to present on this scientific writing workshop. There are two types of variables, numerical and categorical. Discrete are those where you can count, so such as number of days of hospitalization, number of blood transfusion. Continuous data mainly pertains to range of motion assessment or functional scores such as Harris-Hip score or Oxford-Hip score. Nominal category consists of, there is no ranking, so such as blood groups, type of hip prosthesis or nominal data. Ordinal category is for classification such as ASA grading, Gardens classification or open fracture classification such as Testulo-Anderson classification. You have to form the research question first, depending on what you want to assess of any particular orthopedic condition. Then you need to choose the type of study that will best answer your question. Also, it is important to note that it should be feasible in your present workplace. Commonly, there are two types of hypothesis. Null hypothesis states that there is no difference between intervention A and intervention B. Alternate hypothesis can also be used sometimes. Most commonly used is two-sided, which says that either intervention A or intervention B will be better, or it could be one-sided, where it says only intervention A is going to be definitely better than intervention B. And that is very rare to use because before starting a study, you can not conclusively say that. If you have to state that, then there has to be a hypothesis, and also that you need to justify it. If you do a statistical test, the results of the statistical test are presented here, and then this is in reality. So if the test shows significant difference, and in reality there's a difference, then that is a true conclusion, correct conclusion. If the statistical test there's no difference, and in reality there is no difference, that is also correct. Okay. However, sometimes there can be type 1 error, which is false positive, and type 2 error, which is false negative error. In type 1 error, it happens due to multiple statistical tests being done. So if you do about 20 tests, then there is a 64% chance at least one test will be positive. Hence, whenever you're doing multiple testing, there has to be Bonferroni correction to account for the number of tests. Type 2 error deals with when you have an underpowered sample or a sample size is too small, that gives rise to type 2 error. So when we do a sample size calculation, the most important things to consider are power, which is usually set at 80%, alpha level, which is 0.05. You need to consider the the standard deviation of the outcome measure you're choosing. Also, you need to consider the minimal clinically important difference of that value. So this will all help you in formulating your sample size. So for example, most commonly people do thesis. It's a case series. So if you want to look at estimate the sample size for hemiarthroplasties for neck of femur, what you do is you go to the OT register and look at the total number of operations conducted in the orthopedic department. Then you estimate find the total number of hemiarthroplasties done. Then by this you can estimate the prevalence rate. In this case, 2.13. Then you put it into a software. Epi Info is a very good software which helps to calculate sample size and power. So you input these data here. Rest of them are fixed. And then you'll get, like for 80% confidence level, you need a 14 sample size. For 95, you need 31. So accordingly, it helps to form your sample size. Then there is another thing. If you're comparing two groups, then we need to find the standard difference. And for various statistical tests, there are formula available. Then you use the LERS formula where it is formed with the formula 16 divided by standard difference square, which gives you the sample size in each group. You can also use an Altman's nomogram, which has got on this side, you have got the standard difference in various. You choose that, and then here you have got power. So you have to draw a line from, so I have chosen 0.9, and then you draw a line which goes to the power. So I wanted 0.80 as a power, and then this, you see where it is intersecting. This is the sample number of sample you need as per 0.05. So here it is coming to about 38. So that is how you practically use this. You have to do the sample size calculation early in the study. Then you also have to account for there may be patients lost to follow-up. So or attrition will be there. So you have to overestimate your sample size by 15, at least 15 to 20%, only because if you have got more samples, loss of patients, then the study doesn't become underpowered. The outcome measure you use should be valid and has to be highly responsive. Okay, then and the variability also should be low. So the choice of outcome measure is very important. The type of statistical test you're going to use depends on the type of variable, number of groups, whether you have got 1 group, 2 group, or 3 groups, the type of groups and type of data distribution. Independent groups means patients have to are put into 2 or 3 groups and they are not related to each other. Dependent group means the same patient before intervention and after intervention you're measuring, so that is dependent group. Or you may also have an age and gender matched group. So these are all called as matched group or paired groups or independent or dependent groups. This is data distribution. You draw a histogram and then you superimpose a curve. Most of the statistical software will do this. So this is a bell-shaped curve. This is called normal distribution or Gaussian distribution. The one on the middle and the right, this is positively skewed data. This is a negatively skewed data. Both of them are not normally distributed. You can also use other coefficient like skewness coefficient. This is also calculated usually with the statistical software. If the value is between -1 and +1, that indicates it is normally distributed. Value less than -1 or more than 1 indicates it is asymmetrical. You can also use a Kolmogorov's mono test or a Shapiroff-Wilk test. For sample size less than 50, Shapiroff-Wilk test is used. For sample size more than 50, you use the Kolmogorov's mono test. If the test values are significant, then it indicates there is asymmetrical distribution. If it is normal, then it is not significant. Mean is the most commonly used central measure for symmetrical distributed data, and median is used for asymmetrical data. Standard deviation used for parametrical symmetrical data, and interquartile range for asymmetric data. It is important that standard deviation you measure it to 1 decimal point. So if you're using Harris-Hipp score, which is an integer, then you can maximum say 44.1 or something, but it should not be 2 or 3 decimals, like 44.567 or something like that should not be reported. That is too precise. So once that is decided, we have to choose parametric or non-parametric test. Parametric test is used for large sample size, normally distributed data. It is more powerful as compared to non-parametric test. Non-parametric test is used if you have a asymmetrical non-normal data, if sample size is less. So this is an important thing. So for normal distribution, you use mean and standard deviation and then do parametric tests for inferential statistics. For non-normal data, numerical data, use median and interquartile range and non-parametric tests. This table shows various types of tests. Okay, for continuous and normal, depending on the number of groups and whether they are independent groups or paired groups, you use various types of statistical tests. This will all give rise to p-values and 95% confidence interval. 95% confidence interval is more easily given by parametric tests. So the p-value of 0.05 is arbitrary. Okay, so if the value is less than 0.001, it is extremely significant. Value between 0.001 to 0.01 is considered very significant. Okay, we also have to, when we interpret it, we have to make sure that it takes into account the 95% confidence interval. So the 95% confidence interval of difference in mean, median, and proportion. If the 95% confidence interval for the above contains 0, then it is not significant. If the 95% confidence interval doesn't contain 0, then it is significant. Similarly, for 95% confidence interval for odds ratio and risk ratio, if that interval contains 1, then it is not significant. If it doesn't contain 1, then it is significant. Width is important, like narrow interval, 95% confidence interval means more precise data. We also have to interpret not only the clinical significance, but also the not only the statistical significance, but also the clinical significance. So this is a hypothetical data. So 0 is no difference. And these blue lines are the minimal clinically important difference of the outcome. So the lines here is the lower and upper limit of 95% confidence interval. So in number 1, this is not significant clinically as well as statistically because the value is within the MCID. So this doesn't have any effect. Second is this is not statistically significant because crosses 0 but upper and lower limits are beyond the MCID levels. So the results are inconclusive, and we need further evidence to conclude about this. So for situation 3, this is not significant, okay, because the 0 level, this is statistically significant because it doesn't cross the 0, and but this is within the MCID level. So we can say that the variable has small effect but not clinically significant. For 4, we can see that this is statistically significant because it doesn't touch 0, but some values are above the MCID levels. So a variable has small effect and may be clinically important. Well, situation 5, where all the values are above the MCID level, so this is statistically and clinically significant. So this has got an important effect. Okay, so this are a few tables. So you can see that not only the difference mean score is given, but also the 95% confidence interval and p-values both have to be given. This is another example as well. But here the relevance is Osteoarthritis Disability Score, RMDQ, and SF12 MCS. All the scores are clinically important as well as statistically important because both of them are above the level of the MCID. Well, for SF12 MCS, though it is statistically significant but not clinically because the values are less than the MCID levels. The cohort study we usually use to evaluate the prognosis and etiology. Relative risk is the commonly used statistic. If relative risk value of 1 indicates that the risk is the same in exposed and unexposed group. Relative risk more than 1 indicates that there is increased risk in exposed group. Relative risk less than 1 means there is reduction of risk in the exposed group. Okay. Case control study is a retrospective study, and the main statistic used is the odds ratio. So an odds ratio of 1 indicates that the exposure is not related to event. Odds ratio more than 1 indicates the exposure is positively associated with the event, and odds ratio less than 1 indicates the exposure is negatively associated with the event. We would need 95% confidence intervals also to be reported. So odds ratio is to be used to assess risk only if outcome is rare. Okay. So if you want to estimate, want to find out relation between two variables like modified Harris subscore and things, you can use a Pearson correlation coefficient or a Pearson or Spearman correlation coefficient. Pearson is the parametric component and it is used for numerical data which is normally distributed. Spearman correlation coefficient is used when both the numerical data are not normally distributed or one is numerical and other one is ordinal. So let me give a few examples. So the value ranges from -1 to +1. A value more than 0.5 is significant. Okay, and it also has to be accompanied by p-value. Correlation of value of R is 0 is that it means there's no correlation between the components. So here is an example. Okay, this is modified hip score and forgotten joint score. Both of them are normally distributed. So Pearson correlation coefficient has been used. This is a near perfect circle. You can correlation. This is R value was 0.92. Next is you want to look at how observers are looking at X-rays and they are able to look at classify various classification like Gardens classification or Success classification. So inter-rater agreement is for the same all the group measuring looking at the X-rays and grading it at 2 different time frame. Usually between there is a 4-week gap. Intra-rater means this how well the same observer is able to agree with his own self or herself. So if the categorical data is there, for example, ASA for neck of femur Garden classification or Success classification, we use a kappa or a weight kappa level. So kappa value less than 0.20 is poor agreement. 0.41 to 0.60 is considered moderate agreement, and anything more than 0.80 is considered good agreement. So if you have to look at if you're measuring continuous data such as scoliosis angle by Cobb's method or hallux valgus angle, then you use ICC value or intra-class correlation. So if the ICC value is 0, it means no agreement. ICC value of 1 is perfect agreement. ICC value of more than 75 is supposed to indicate excellent agreement between the observers. Another example. So you can see the p-values are significant and also the 95% confidence interval of the kappa value and the interpretation. We can see that the first reading and second reading. In the second reading, the kappa value increases significantly. Also, this is for slack wrist or scapholunate advanced collapse. Then you look at various stages, and you can see the maximum agreement amongst the observers is during for stage 3. So less agreement during stage 1 and 2. When you want to validate a study, we look at correlation. So there are the correlation between two scores like Harris-Hip score and the forgotten joint score. Convergent validity means again correlation amongst outcome measures which measure same domain. Divergent validity means there will be less correlation amongst outcome measures which measure dissimilar domains. For example, Harris score will have less correlation to SF36 or SF12. Reliability, two types of reliability are there. One is internal consistency, which is measured using Cronbach's alpha. Okay, it shows how good the correlation is there amongst various items of a questionnaire. So value more than 0.95 means probably two items are measuring the same domain. So that needs to be removed. Test-retest reliability is also measured. Responsiveness is measured using standard response mean, effect size, receiver area under curve, and MCID values. So this is an example of Liverpool elbow score where effect size and standard response mean based on various satisfaction levels is seen. So as the effect size in SRM increases as per the satisfaction of level of the patient. So this is a ROC curve showing area under curve of various outcome measures. You can see that the Roland-Maris disability score and Oswestry disability index have got higher area under the curve as compared to other measures. The MCID value is also a component of responsiveness. The area which is on the ROC curve, the one which is closest to the top left corner, indicates it is significant. Regression studies are used when you want to measure association between variables which more than 3 or 4 variables. So if you have got a numerical variable, then simple linear regression or multiple linear regression is checked. Regression is used for basically prediction. So if you have a numerical variable here as y, then you can this x can be either a numerical variable or a ordinal variable. Okay. Multiple linear regression is used mainly to look for confounding factors. Also, there can be multiple values which may be predicting a numerical variable, such as peak pressure, etc. Logistic regression is mainly used for data which is dichotomous, like union or non-union, alive or dead, infected, not infected. Similar regression. So the goals for if you want to compare a new test along with CT scan or anything which is a gold standard, then you look at prevalence, sensitivity, and specificity. So for a condition which is easily treatable, sensitivity is important, but for a condition which is less easily treated than or very difficult diagnosis and untreatable condition, then you use specificity. For us as clinicians, positive predictive value and negative predictive value is more important. Survivorship analysis is done using Kaplan-Meier analysis. Okay, 2 different groups have been compared: patients with osteosarcoma and their survival without pathological fracture is the top one. The one below is those with fracture. Okay, so the survival rate amongst osteosarcoma patients is higher with patients who do not have a fracture. So this comparison has been done by log rank test, which is a non-parametric test. The p-value is 0.02, hence significant. When we do a meta-analysis, is another type of study which is important. We have to choose the effect size statistics. So if it is a binary endpoint, we use relative risk. If it is continuous data, we use mean or standard deviation. We also have to look for heterogeneity. So if the heterogeneity is less than 25%, we use a fixed effect model. If it is more than 25%, we use a random effect model. And when we compare, basically for the statistical test for pooling, if all the outcomes are similar, such as if all the studies have used Harris-Hip score, then you use something called as a weighted mean difference. However, if some studies have used Harris-Hip score, some have used Oxford Hip score, you will use something called as a standardized mean difference, which will account the discrepancies. We also have to look for heterogeneity. So if the heterogeneity is less than 25%, it is low. If it is more than 50% and less than 75, it is moderate. And if it is more than 75, it is significant heterogeneity. You have to find out the cause for the heterogeneity. Publication bias is assessed using, this is a curve which shows significant difference. And this is a forest plot. In the funnel plot, it has to be symmetrical with equal distribution. So this is minimal bias. Here, there is significant bias because this part is missing. So there is significant publication bias. Okay. So in conclusion, when we do a statistical test, when you plan it, choosing the right test is important, because if you do not do it properly, then it is going to jeopardize the internal validity of the study, giving rise to bias. So do it before you recruit the patients, formulate all the hypothesis should be formed before the test, choose the correct statistical test, always quote p-value and the 95% confidence interval, and always comment on whether the data is clinically significant as well, in addition to statistical significance. Thank you very much for your attention.